Hi, I'm here at the 2017 ASCO annual meeting, and I'm going to talk about 3 oral presentations on CLL. The first one was the previous intergroup study, which compared FCR to FR. And there were actually a couple of arms in that trial. Patients were randomized to receive either FCR, and this is frontline therapy, or FR, or there was a third arm, which was FR, followed by 6 months of lenalidomide maintenance, or there was a separate arm for the patients with 11q deletion. And those patients all received FCR and 6 months of lenalidomide maintenance. The reason that the 11q had a separate arm is when that trial started, there was pretty good data that had emerged suggesting that cyclophosphamide was a very important drug in the patients with an 11q deletion. So we have 3 non-11q deleted arms and 1 11q deleted arm. And what they showed is that the FCR in the non-11q deleted was providing the best progression-free survival and the highest CR rate, although there was no statistical difference between the progression-free survival in the FCR versus FR followed by lenalidomide, although the curves were somewhat different. But there was a significant difference between FR and FCR, attesting to the importance of the cyclophosphamide in that regimen in the non-11q deleted. In the 11q deleted, of course, we didn't have a comparator arm, but my take on the data is that the data that they got for FCR with 6 months of lenalidomide is probably not a lot different than what you would have expected from FCR alone. The only interesting thing about the lenalidomide finding was that, well, it did seem to make FR better because the PFS was better. But it was very interesting that although it was statistically not significant, if you looked at the overall survival curves, there appeared to be a plateau on the FR followed by lenalidomide out at about 4 years. It's a little hard to understand, given that the fact that the lenalidomide was only given for 6 months, why that might have a very late effect on the survival curve, unless it's a fluke and it's just early. As I said, it wasn't statistically significant. So we'll have to see with longer follow-up if that holds up. So I think it clearly indicated that FCR is the best standard regimen for fit younger patients with CLL. Of course, in the current intergroup trials, which are fully accrued, but we haven't seen any data from them yet, we have two comparator trials comparing BR to an Ibrutinib-based regimen or FCR to an Ibrutinib-based regimen. Again, those trials are fully accrued, but we have to wait to see data from them. That was the follow-on intergroup trials. I would say, however, that probably the window for lenalidomide in CLL is closing. There were 2 randomized trials where it was used after chemotherapy, both showing significantly improved progression-free survival in CLL following chemo, but no overall survival difference. Which is probably not that surprising because when those trials started, we didn't have all the novel oral agents, right? So now we have Ibrutinib, venetoclax, idelalisib, and so we have a lot of agents that can provide good remission durations after patients relapse from chemotherapy. So we're unlikely to see a survival advantage in those trials. I think it's unlikely that they will be able to get an FDA approval without a survival advantage. It's unfortunate because it's a very active drug, but it does cause a lot more neutropenia than we see with the other oral agents. They all have some degree of neutropenia, but certainly lenalidomide has more. So we'll have to see what happens with that drug in the CLL setting. There's obviously a lot of excitement in the lymphoma setting with the R-squared regimen. The second abstract that was presented was the data from a randomized trial in relapsed CLL where patients were randomized to Ibrutinib or Ibrutinib plus ublituximab. And ublituximab is a novel anti-CD20. It's a type 1, but it's glycosylated. And what that trial showed is that the overall response rate was significantly greater with the 2-drug combination. However, they don't count the PRLs as responses. We know that the pattern of response with Ibrutinib is that in at least 80% of relapsed patients, right, they have a lymphocytosis. And it can take quite a while for that lymphocytosis to resolve. So when you look at the early response rate, if you're not counting PRLs in the response, you're going to have a relatively low response rate, although that's going to go up over time. So the real question is, how much does the antibody really add versus just getting a more rapid response by abrogating the lymphocytosis. There were some hints that it might do more than just that, because they did show data adding the PRLs into the response rate, and the response rate overall for the combination was still higher. So that's kind of interesting. Maybe it's not all the effect on PRL. They had not a high CR rate, but they had MRD negativity in the combo arm, which you generally would not see in relapse setting with Ibrutinib. And although there was no significant difference in the progression-free survival curves, and by the way, the study is not powered to show one, it was interesting that the PFS curve for the combination was the one on the top. So I think it's just too early to know. We already knew from prior trials with rituximab and Ibrutinib that you can get a much more rapid response, get to that PR more quickly. And certainly we saw that here. But is it really going to have an effect on the long-term outcome in terms of better PFS? I think it's just too early to know. The third trial that was presented was a review of Richter syndrome in the era of novel agents. So a number of different centers, probably about 10, got together and looked at the data combined for patients who developed Richters on, again, the new oral small molecules. So what's important about this is it's the largest series ever on Richters, plus it's in the current day and age, if you will. And suffice it to say that that is still a very high-risk group, which is truly an unmet medical need in CLL, because those patients have a dismal survival. Now, they're usually patients who've failed chemotherapy. Now they're relapsing after a novel agent, and so they're a very high-risk population. And sure enough, as has been shown in smaller series, they tend to have very high-risk characteristics, so lots of 17p, complex karyotype, notch mutations, et cetera. They tend to be a high-risk population in general. But the overall survival was on the order of a few months. Mostly those patients received typical large cell lymphoma regimens, or EPOC, or CHOP, et cetera. Most of the responses that you get with those regimens are partial, and they're not very durable. Ideally, what we try and do is get a reasonable response, and if the patient is young and healthy, take them to a stem cell transplant. In fact, 2 of the long-term survivors were patients who were able to go to stem cell transplant. But the median survival was on the order of a few months. So this is really still a high unmet medical need. Now that we're moving more away from chemo, perhaps the incidence will go down because we won't have chemotherapy with its genotoxic effect on the DNA. We don't know that because, as I said, most of these people have not just had small molecule inhibitors, but had previous chemo. So maybe the incidence will increase over time. They did show the incidence on some of the data using the small molecules as frontline therapy. Obviously, that data is very limited with very short follow-up, and the percentage is much lower. I think not unexpectedly in a frontline setting. Even with chemotherapy in a frontline setting, the incidence of Richters is not that high because it tends to be in the heavily pretreated patients. So it was important data because it really does still show us that this is a real unmet need in the area of CLL.